Hello, good evening, everyone. So last time we had a surgical video regarding total femur replacement, and today we are just going to cover a sub part of it, that is the proximal femur. And I think since we discussed a lot about the anatomy, the applied anatomy, the biomechanics of implantation, this topic will look a bit easier as compared to total femur. But I think it is an interesting topic because not just for your tumors, but even for sometimes very comminuted fractures of the proximal femur, when you don't have a salvage option, these proximal femur implants are very much in hand, and it may bail you out in these situations. So normally, you know the difference between a total femur, proximal femur versus a conventional hip replacement. So what you see on the right side is a conventional hip replacement, where the cut is through the neck and you insert the implant, you get the acetabulum socket prepared, insert the implant with cemented or uncemented. So that's the conventional way. And normally in these situations, all your muscles are intact, which means like the attachment of your gluteal muscles over the trochanter, part of your iliacus and psoas, which attaches over the lesser trochanter, all the muscles, the anteriorly you have the rectus femoris from anterior inferior spine, which goes down, your sartorius from ASIS, which travels and covers. So all these musculatures, everything is intact. You just go in and cut at the neck, insert the implant, your soft tissue structures are preserved. But once it comes to the tumors, especially in the proximal femur, and like I have explained, these require surgical resection with wide margins, which means what does a conventional the proximal femur will look like? The proximal femur, where you do not replace just the bone. So this on the left, extreme left, what you see is a proximal femur with a permeative type of lesion. You see here all lytic pathological fracture, and in this situation, when you need to resect it, you need to do it with wide margins. And how do we do that? That in such situation, you have to cut the bone. It's a intra-articular dissection. You remove the head and everything you excise en bloc. So it becomes a very unstable situation. So you need an implant which gives you inherent stability. Unlike hip and knee, where you have constrained type of prosthesis, the stability in proximal femur depends upon other structures, the soft tissue structures which are there, and we need to look at those aspects. So with this, let us see what are we going to learn today. We are going to learn the applied anatomy, the practical anatomy which we are going to face when we do the exposure, when we start operating. I think surgical planning is very important. We need to understand what all is required whenever we see a tumor case, which approach we should use, what are the different techniques. And finally, today I have an interesting case of proximal femur sarcoma, for which I will demonstrate you a step-by-step approach, the way we plan the dissection and then the reconstruction. So as usual, anybody from third year, we will like to keep it interactive. So let's start. So how is the anatomy? What type of joint is hip joint? Anyone? बोलो भाई, ये तो बड़ा सिंपल सा है. कौन सा, what type of joint is the hip joint? Okay, I have to see in the chat. Right. Ball and socket, Ram Mohan. Good. So ball and socket joint. Now, how do you, what are the critical structures that we see when we have to plan a surgery? So let's see the stability of the hip joint. On what structures does it depend? So like I always tell you, you can unmute yourself and tell me also. In that way, I also don't feel sleepy and you also are awake. So anyone? Yes.
Yes, sir, the stability of joint.
Hmm.
Stability of joint with the abductor mechanism plus the socket acetabular version
Okay.
and femur
Right.
anteversion, safe zone of acetabular joint.
Right. So one is because of the bony architecture that you
Yes,
have
sir.
uh, cup where the ball of fits inside, and because it creates a lot of vacuum which holds it in place. But that is not just enough. We have the other soft tissue structures which gives it stability. So what are the different soft tissue structures which you see which gives the stability?
Sir, labrum, Y ligament,
Very good.
capsule.
Yeah, so you have all this labrum and then the capsule. Which ligaments?
Sir, ligamentum teres and Y ligament, capsular thickening.
So ligamentum teres is somewhere there. And then which ligaments?
It's Y ligament, ligamentum. It's capsular thickening.
There are iliofemoral,
Iliofemoral. Yes, yes.
femoral,
Sorry,
all these ligaments are there.
ligaments. Yes, sir.
So these are very strong ligaments actually. So
Yes, sir.
they hold the trochanter in place. And then apart from this, the attachments, like you correctly said, the muscles,
Yes,
like your abductors. So it's
iliopsoas.
all around attachment. It is not just the one muscle, but the
Yes, sir.
entire muscles. Your iliopsoas will get attached over here. Your abductors, all these muscles ultimately gives inherent stability. So when we plan a surgery, we need to resect all these structures one by one, and that will lead to a gross instability in these cases. I'll show you
Yes,
the examples in the video once we have resected how it is. It is not like a hip replacement situation where you have all intact soft tissue structures which will hold the implant. So we need some very inherent stabilizing structures which are important.